Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to today's event. The theme for today is Key Issues in Obstetrics and Gynecology. We have three immaculate, wonderful speakers who are going to talk to us about three different topics in today's event. Before we start the scientific proceedings, I would like to express my gratitude to the AMOG's office bearers. Next slide, please. Our beloved President, Dr. Nandita Palshetkar. Madam is the current president of AMOG. She's also served as the president of FOXI, the Mumbai Society, IAG in the past. Soon she is going to be installed as the president of ISAR as well. Thank you, ma'am, for your blessings, your guidance, and your support to all of us youngsters who follow in your footsteps. Next slide, please. I would also like to express my gratitude to Dr. Arun Nayak. Sir is a fantastic vaginal surgeon, a distinguished academician in his own right, and he is currently the secretary of AMOGS. Thank you again, sir, for blessing all our academic endeavors. Next slide, please. At this stage, I would also like to express my gratitude to the ICOG office bearers, our chairperson of ICOG, Dr. Uday Thanawala, the secretary of ICOG, Dr. Ashok Kumar, and thank you, sirs, for your blessings and for the ICOG credit points for all the events which we have done during the lockdown period, during the pandemic, and of course, today's event, which is accredited with one ICOG credit point. Before we proceed further, I would also like to say that I am standing for the post of managing committee member of ISAR, as you must be doubtless aware. And despite all the trials and tribulations of trying to vote over the past 1 week, finally, I think the issues with the voting server have been sorted out. So if you have not cast your vote so far, then I would humbly request you to please go and exercise your right to vote, and please spare one vote for me. Thank you so much. Next slide, please. We have four wonderful academicians who are going to be chairpersons for today's event. First and foremost, we have Dr. Kiran Kurtakoti, sir. Sir is the second vice president of AMOGS. He served AMOGS in various different capacities, including chairperson for the MTP committee. He's also been chairperson for medical education, research and training. Also served as the second joint secretary of AMOGS way back in 2009. He's also been the chairperson for the MTP committee of FOXI, and he is well known for his publications, presentations, and as a distinguished faculty at several conferences all over the country. Next slide, please. We also have with us Dr. Padmaja, who is well known to us in fertility circles because she's a fixture at every fertility conference that I go to for the past 10 years at least. She's very well known in fertility circles, especially in the South, because she's served as the chairperson of the Andhra Pradesh chapter of ISAR, and she's recently handed over to the next person. But she remains an integral part not only of ISAR, but also the PCOS Society. In fact, she travels all the way to Mumbai whenever Dr. Durusha has a conference. Dr. Durusha is the president of the PCOS Society. Padmaja is one of the main faculty who is there at almost every conference. She has a long and distinguished career with several medals to her credit, and she is also somebody who is well known for her academic powers. Thank you so much, ma'am, for being here with us. Next slide, please. We are distinguished to have today with us Dr. Rohan Palshetkar, the young gun and the up-and-coming fertility clinician from Mumbai. Dr. Rohan Palshetkar is the head of unit at Bloom IVF, KY Patil. He is also the West Zone coordinator of the FOXI Young Talent Promotion Committee. More relevant to today's event, he is the second joint secretary of AMOGS and was recently elected to the treasurer post of AMOGS, which he will take over very soon. He is well known as a managing committee member of the Mumbai Society, Maharashtra chapter of ISAR, also the Maharashtra chapter of IAG. Innumerable awards to his credit. Thank you so much, Rohan, for joining us today. I know you have a cesarean waiting, so we'll try and relieve you very soon. Thank you so much for being here with us. Next slide, please. And last but not least, we have Dr. Hafizur Rahman from the Sikkim Manipal Institute of Medical Sciences at Gangtok in India. Sir is a distinguished academician. He is a professor of OBGYN. He's also a co-member of the ICOG Governing Council with me, and we've collaborated on so many different ICOG functions together. He was there part of the ICOG Governing Council meeting recently and the convocation which we had, first time ever, the virtual convocation. So it's always a pleasure to have Sir with us. He again has to his credit several awards, including the Foxy Future Award, the IIC Sun Traveling Fellowship Award, the Praveen Mehta Fellowship in Laparoscopy, Kaminu Rao Yuva Orator from the East Zone. So many different publications, presentations to his credit. It's lovely to have such distinguished faculty on the Amox. Welcome, sir. We have three eminent stalwarts, as I said, who are going to speak to us on three different diverse topics. The first of these is going to be Dr. Dilip Walke, sir, from Pune. He's going to be speaking to us about medical legal pitfalls in OBGYN. We have Dr. Supriya Jaiswal, who's the secretary of the Patna OBGYN Society, talking to us about sustained release progesterone in clinical practice. And last but not least, we have Dr. Tabassum Dalla from Raipur, and she's going to be talking to us about something very unique, and that's intrapartum ultrasound. So having said my little bit, I would like to now hand over the proceedings to the chairpersons, and I will recede into the background, request you to take us further through the academic proceedings for today. And I would request Dr. Rohan Palshetkar, sir, to introduce the first speaker of the day, Dr. Dilip Walke.
Thank you so much, sir. Firstly, I must thank you. You're always including me in all the programs and giving me this opportunity to be among so many stalwarts in our fraternity. So thank you so much, Pratik sir, and I wish you all the best for the ISAR elections as well, sir. I've voted thrice already through all three portals. So now I'm well versed with it. I'm helping everyone else also get logged in and vote as well. So wish you all the best. So without taking too much time, I would like to introduce our first speaker, Dr. Dilip Walke, sir. I think sir requires no real introduction. Sir is a fantastic speaker, especially on all the medical legal aspects in our fraternity. And he's been helping out so many of our gynecologists with all the possible pitfalls. And I think, sir, this is the ideal talk for you. Just to give a formal introduction about sir, he's a consultant at MediPoint Hospital and Jupiter Hospital, Pune. He's been the chairman of the Ethics and Medical Legal Committee, Foxy 2007 to 2010. Sir was the president of the Pune OBGYN Society in 2019 to 20. And he's the founder director of the DRAX Telemedicine Solutions as well. Sir, I hand over the platform to you. We're really looking forward to your talk as well, sir.
Thank you, Rohan, for that kind introduction. And I'm looking forward. Actually, I'm missing all those banquets where you dance during the banquet. So I'm missing seeing you dance now, actually. Enough of seeing you on a web platform. Okay. So I'll share my slides. And can you see my slides?
Yes, sir. We can see your slides, sir.
Please full screen, sir. Yeah.
Yeah. So I get started with thanking everybody, especially all those AMOG's office bearers, Nandita, Rajendra, and Rohan for introducing me. And I think maybe Kiran is busy in the Endogyne conference, but thanks to Padmaja, Hafizur Rahman, who, if they are there, thanks to them for chairing the session. First, a disclaimer, I am not a lawyer. I do not understand the IPCs and I don't remember case laws and sections from the various acts. Then why do you think Pratik must have given me this talk? This reason is very simple, because Pratik knows my secret. I have in the past listened to Dr. Gupte, Dr. Pawar, Dr. MC Patel. Now I am listening to Dr. Gitendra, Dr. Nikhil, Manish. And recently again also I listened to Alka and Rahul Mani. And what I do is I decode all the legal jargons that they use in their talks. And I add my tadka of abundant caution in clinical practice. And I present it in front of you as carry-home messages, and that is my secret of whatever the talks I give on medical legal aspects. So the agenda for today is to have a look at very simple day-to-day pitfalls that we have in our OPD or our labor room or our OT or in the ward, and what is the typical advice that our medical legal experts give to us to avoid these pitfalls. Then we look at what are the challenges to follow these advices in our small practices. And then we'll come with very simple solutions and carry home messages, especially the target is small nursing homes. I request the chairperson to stop me whenever the time is up, because when it comes to a medical legal talk, I can go on and on for hours together. So please stop me when the time is up. Advice number one, the medical legal experts always tell us that the OPD record should be maintained by us and the patient should receive only prescriptions with advisors. And the reason why they say this is because by giving the OPD record to the patient, you're actually handing over your defense of contributory negligence, if it is there, to the patient, and you will not have that with you to produce in the court of law. And what is the example of simple contributory negligence? In simple words, if you can prove that with documents that you had advised some investigation, say an anomaly scan and the patient did not do it, or you had advised the patient to see a physician and patient did not go, or you had advised follow-up and patient did not follow up with you, or patient hid from you the history of allergy or any other important thing, and so on. And now if complication occurs, the patient is likely to be held partly or fully responsible for it, and the compensation, if any, may be completely waived off or compensation will get reduced. So no more excuses like time nahi hai, heavy OPD hai, I am understaffed, I cannot do that. या क्या फर्क पड़ता है अगर नहीं OPD record रखा तो? There is no alternative to this. You will have to now look out for good OPD software so that your records are maintained for a long number of years. The advice number 2 is records are your saviors in the court, and so you have to preserve them. So the next question, which is usually asked in all the medico-legal conferences, for how many years? And this is the slide which most of your medico-legal experts will show you. MTP documents, 5 years, PCPND documents, 2 years, and now the new ART Act has come. Those documents are supposed to be kept for 10 years. Your surrogacy-related documents for 25 years, IT-related 7 to 8 years, MCI says 3 years. And since the limitation period in a consumer case is 2 years and a civil case is 3 years from the cause of action, so we always say that you preserve your papers for 5 years. And if you feel that there is a criminal liability in a case, then you keep it for lifelong. However, now, today, I disagree with this slide because I feel my argument is that we are preserving our documents for our safety in the court. Cases can come up after several years, and by that time, we may forget the details of the case. So what I say is we are preserving our papers for our memory. So we have to preserve our records, and it should not be seen as a burden. We have to preserve it forever for ourselves. So scan and store the records that you have in the OPD or in the indoor and make use of all the technical advances, store it on the cloud. Of course, everybody knows that whenever demanded by the patient or a legal head, the case papers or the copy has to be handed over within 72 hours after a written request from them. This everybody knows. Another thing that they tell us is that forgetting important investigations like an anomaly scan or a blood group or aneuploidy marker, etc., can be seen as an act of omission. What is this act of omission? What an averagely skilled doctor of that branch, that is an averagely skilled gynecologist, would do in that situation, if it was not done, then it's an act of omission, and that can be considered as negligence. So the solution to this forgetfulness that we have in our practices, printed pre-pregnancy profile in case of obstetric case, handed over on the first visit itself. I mean, you give a printed format of all the investigations to be done. Say at the first visit, when she is 11 to 13 weeks, then when she is 18 to 20 weeks, when she becomes 24 to 28 weeks, all the different investigations that we advise as the pregnancy advances, you give it in a printed form on the first visit itself and take it in writing that she has received that pregnancy profile. Of course, printed format for pre-op investigations can also be one way of seeing to it that we will not forget any investigation. And you have to remember that just handing over this is not enough, because it's not just enough to advise investigation. You need to do counseling about those investigations also. For example, look at this recent Bangalore case, wherein a triple marker showed that it was low risk. No counseling was done about this triple marker test. And in fact, assurance was given that pregnancy is going to be okay, and she asked her to continue the pregnancy. Baby had Down syndrome. Now, is there negligence? Here, it can amount to a little bit of negligence because proper counseling was not done to tell that when it comes to an aneuploidy scanning, double marker or triple marker or quad tests are only screening tests, which we have to tell the patient. Low risk does not mean no risk. High risk does not mean 100% risk, and all this needs confirmation. High risk needs confirmation with amniocentesis or chorion villus biopsy. These kind of counseling we have to do. Now, the moment I show this slide, people say, "Ye sab OPD mein batane ke liye time kiske paas hai?" And it's very difficult for when your OPD is running, you have got 25 patients waiting outside. It is very difficult to talk about all this in your OPD consultation. So the solution to this is to conduct pregnancy classes for all your obstetric patients. And in the pregnancy class, At one go, you can talk to all the 25, 30, 40 patients who may be coming for the pregnancy class and explain about this to the pregnancy, to all the pregnant women who will be attending those class. And you can then maintain a document that this patient had attended the class and I had counseled her about all these endocrine markers or whatever test that you may be doing in your pregnancy. Expert advice number 5, follow textbook protocols, FOXI and Government of India guidelines, because judges refer to this while deciding whether a standard treatment was given or whether reasonable care was given, offered to the patient. All this reasonable care and standard treatment is all that is there in your textbooks or your protocols or your FOXI or Government of India guidelines. Have a look at this case and you will understand what I'm trying to tell you. There was a patient with fever between 32 to 34 weeks, and in this case, TOG was not done. An IUGR baby delivered prematurely at 36 weeks, and the baby later was found to be having cerebral palsy, and the allegation was TOG was not done in this case. Now, the doctor presented the FOXI guidelines, and the court accepted that TORCH is not a routine screening test, and it is indicated only if there was fever in the first trimester, and that cerebral palsy cannot be diagnosed antenatally. So that is how this doctor made use of the FOXI guideline, and because of which he was considered not negligent. Another advice, we must have checklists and protocols in our practice, because if checklists have brought down the errors in airline services, the same can be achieved in medical services also. So otherwise this will happen. See, like a patient is RH negative and you missed giving antenatal MPD, or the patient had low AFI and you took it easy and there was IUFD, or the patient had high blood pressure with urine albumin 1+, you did not take any action and later on there was severe PI, or there was headache and you just prescribed crocin, or the patient had severe preeclampsia in labor, liver enzymes were not done, so on and so forth, or a wrong side or a wrong patient. So these kind of things can happen if you are not following proper protocols. And that's the reason why now, because of the NABH entry level, almost all of us are forced to at least follow the OT checklist. But I look upon the AMOG celebrities to prepare protocols for all our clinical scenarios so that none of our AMOG members will make any mistake when they are actually treating a particular clinical scenario. Another advice, choose your cases well for small nursing home and refer all the high-risk cases to institute, and ensure proper infrastructure of nursing homes or hospital where we are called to operate. Now, this particular case sent a lot of tension all around the country, because in this case, we started thinking that even small nursing homes need to have ICUs. But actually, in this case, the Supreme Court merely commented that the question of whether a small nursing home needs to have an ICU facility was not argued by both the parties, and the case had already taken a long time, 24 years to almost 24 to 25 years to reach this stage of judgment. And that's why in the Supreme Court, and that's why the Supreme Court actually just parked this issue of whether small nursing homes need to have an ICU facility or not. And the gynae was held negligent in this case because an obese, hypertensive and diabetic patient was operated upon in a small nursing home. So what is important, the case was about wrong choice of the patient and not about whether ICU is needed in a small nursing home or no. So for the benefit of all my fellow supari surgeons, the supari surgeon is the one who goes, somebody calls him, either aake ek hysterectomy kar le kar, aake ek cesarean kar le kar. So whenever you go to the small nursing home, see to it that the oxygen cylinder is filled, see to it that there is defibrillator, now even an anesthesia workstation. See that even the laryngoscope has got batteries. I'm giving all these examples because there have been court cases because these things were not followed in a small nursing home. Drug expiry, whether boils and all the circuits were checked, whether there was a proper stock of disposables, where a copy of purchase vouchers of disposable was there, whether generator was there, whether regular swab report and was maintained in the OT, whether fumigation and autoclave register were maintained, whether the OT lamp is good enough or it does the table have a head low facility. I mean, there are many small nursing homes where there are operation theaters where there is no head low facility also. Are all the instruments properly equipped, and is the setup geared up for giving general anesthesia in case spinal anesthesia fail? And this I have actually suffered at many places wherein spinal फाइनल तक कर सकते हैं लेकिन जीए की कोई भी यहाँ पे व्यवस्था नहीं है. So this can be a problem with the spinal anesthesia is inadequate when you are operating in a small nursing home. Another question is, many times people ask me, what is prudent, being bold and bindas in practice or being fattu? And my advice is, be seen as a fattu doctor, but be smart and not bold and bindas and reckless. Because in my practice, what I do is simple: any pregnant women with tachycardia or murmur, immediate physician reference. 140/90 physician reference. All mild GDMs and hypothyroids, physician reference. Mild additions, I call the surgeon to assess. Query bladder injury, I can actually suture it, but I call a neurosurgeon. Post-op event, surgical reference. I may sound like a fattu practitioner when I say show you this slide. But what I am is I am too smart, because later on, if this case goes in the court, I can prove in the court that I was abundantly cautious and had a multidisciplinary approach. And I ensure that in case of complication, I will not be dragged alone in the court, and my surgeon, my physician, and all the neurosurgeons will also get dragged in the court, and I'll be able to defend myself better. Now, these two cases from Pune, you can just have a look at it and you'll realize why is it important to have a multidisciplinary approach and why is it important to take proper references. Antenatal record of visit in 9 months showed tachycardia and breathlessness. Every visit there was an evidence of tachycardia and breathlessness, but all this the doctor did was, in pregnancy ye to hota hai. No physician reference was taken. Patient died 4 days after delivery due to cardiomyopathy. Again, in this another case, antenatal visits uneventful, LSCS uneventful. On the 8th post-op day, patient in ICU diagnosed as tight MS, which means there must be some murmur heard when the patient was in antenatal period and physician reference was not taken. Now, a few pitfalls and solutions when the patient comes in labor. The first situation is about, this is what advice which Dr. Gupta told me several years back and I endorse it. And that advice is do cross-matching for every patient that comes in labor. Because Dr. Gupta told me 80% of medical legal cases faced by gynecologists or obstetric cases are on gynecologists and obstetrics. So these are all the 80% of the cases. 80% of these cases are related to hemorrhage. And 50% of the cases occur in cases where it was not expected, that hemorrhage was not expected. So our usual defense in the court of law is hemorrhage is a known complication of labor or LSCS. Then the next question that will come in the court is, what did you do to anticipate, to prevent, and to manage this? And then we'll have to show something that we did to prevent it, and we are doing cross-matching can prove that. Have a look at this case, Rashmi Fadnavis case, a very old case from Bombay. Obese, 124 kg, A negative blood group, hysterectomy for multiple fibroids in a small 5-bedded nursing home in Mumbai. Only one oxygen cylinder, that too was empty, blood not cross-matched, prolonged surgery for 7 hours, death due to profuse bleeding. At that time, so many, 25 years back, 2.6 lakhs was awarded because the court said that should have done in a bigger institute with blood cross-match. So the importance of sending blood for cross-matching is very important, because you have to ignore all these arguments which some of the medical legal experts give, that routine cross-matching puts a lot of pressure on the national store of blood. See, we are not asking for blood. We are just cross-matching and keeping it ready. So we are not putting any pressure on our national storage of blood. They say you are unnecessarily increasing the work of blood banks. In fact, the blood banks are very happy to do cross-matching because that is where they earn their money. They are not earning money on the blood that they give, because that is supposed to be a donation and they are not charging for that. And they say it incurs extra cost to the patient. I think just a few 1,000 rupees here and there doesn't make a difference when they're going to pay such a big, huge bill for your delivery or cesarean. And lastly, many of these medical legal experts will tell you, "Itna dar lagta hai to practice band karo," but you must tell them कि डर के आगे हमेशा जीत होती है. My personal advice, again, when for a patient in labor or when you're doing an LSCS, but definitely when you're doing an LSCS, but when the patient is just for a normal natural vaginal delivery, call anesthesiologist. And you may feel that I'm calling my anesthesiologist for labor analgesia, for epidural, but I don't not only call them for epidural, but I also call them for monitoring the vitals, because an anesthetist is the best person to do that. I also call them to keep a watch on the CTG when I'm at home, because I have taught them how to read CTGs, and also they give good fundal pressure when needed. And of course, this is an off the mic statement. You cannot quote anywhere, but my anesthetist gives wonderful fundal pressure for delivering the patient vaginally. However, anesthetist is the most difficult consultant to find when you actually need them in labor. So I have found a way out for this problem. You may choose to find your own way. I married one anesthetist, so she is always available for any of my patients in labor. Now, consent related issue for patient in labor. Now have a look at this case. Patient in labor, you took consent during pain for non-progress. LSCS was done, there was complications, and the case is in the consumer commission. Patient says, I was in pain. I could not understand what the doctor said. I signed wherever he told me to sign. And the lawyer will also say that it is not a valid consent because the patient was not in a mental condition to understand the counseling that was done before taking her signature. Now, how will you defend such a case? And that's the reason why in my practice, in the antenatal classes that I take in my practice, I already have told them about the possibility of cesarean, the possibility of non-progressive labor, and all the indications of cesarean I may have told them during the antenatal class, so I can prove that she was counseled about it. But most importantly is this FOXY advice, that is the advice number 10 for today's presentation: take consent for vaginal birth. And this you will find on the uniform consent document that is there on your FOXY website, in which Dr. MC Patel, myself, and Dr. Nikhil Datta took a lot of efforts into coming out with a document also for vaginal birth. And what we say is, you take this consent for vagina, you may call it consent, you may call it counseling, or you may call it information booklet, or whatever you may call, but you take a signature for having received this information from the patient once in the antenatal period, and again when she comes in labor, because hospital birth is often with interventions like fluids, like episiotomy, unforeseen emergencies. And what we say is, take a separate consent during labor in case of emergency, like you are going to do an instrumental delivery or an LSCS or an MRP. You also take another consent for this specific intervention, but you must have a consent for natural vaginal birth also taken once in the antenatal period and once when the patient comes in labor. Another situation, you took a patient for LSCS, you found an ovarian cyst. Now, medical legal experts all over the country will advise you not to excise unless there was a prior consent taken. However, seniors who are sitting here, who are attending this, will vouch for it. In the good old days, in good faith, we used to use our wisdom, call a relative inside the OT, used to show the cyst to them and tell them it is better that we operate it right now, and we used to operate upon it. Now, where has that wisdom gone? So what we have done in the FOXY consent, we have included this particular clause, which goes like this. I'll read it out for you and you will understand. The patient says that I understand that during the course of the surgery, the doctor may find another unanticipated, unhealthy condition that may need specific action, procedure, or surgery. If the doctor feels that it will be beneficial to treat such condition while performing the proposed surgery, and if I am not in a mental or a physical capacity to give consent because I am under anesthesia, the doctor may take necessary decision after discussing with Mr. or Mrs. So-and-so and whatever is the relation to the patient. And I authorize the above mentioned person to give my proxy consent on my behalf. So this is what we have included in our FOXY consent, and the patient may choose not to actually give any proxy for us, but if she wants to, she can tell that this person is going to be my proxy. Even when we actually included this in the FOXY consent, we thought that it will not be allowed itself, because the Samira Kohli versus Prabha Manchanda case is saying that this is not allowed. So we thought that this will not be allowed, but to our surprise, a law institute, two retired Supreme Court judges, consumer activists agreed that it is possible to take such a proxy consent before any consent given. And not only that, they said not only it is possible, but it is ethical to do so. So till there is a case law, we have included it in the FOXY consent, and till there is a case law, we are not too sure whether our courts are going to accept it, but there is no harm in trying and no harm in taking one such consent, so that if anybody falters and anybody does a surgery in good faith like that, that person will be actually covered by this particular consent clause. Now, at the end, I'm going to talk about the maternal death issues and the questions that come to us whenever there is a maternal mortality. The question number one is it mandatory to call police for every maternal mortality? Like a patient came to you and the patient died because of postpartum hemorrhage. Is it mandatory to call the police? Number one. Number two, is the onus of asking for a medico-legal PM upon us or it is upon somebody else? Number three, can we give a cause of death if it is known? Like in case of a PPH, cause of death is multi-organ failure due to severe hypertensive shock due to PPH. So can we not give this cause of death? And three, is it mandatory to do postmortem in all maternal mortality cases, as there is going to be death review by the appropriate authority? So we'll have a look at all these questions and we'll come to know what are our legal rights and what is it that we should do for abandoned caution. Point number one, should we call police for every maternal death? The answer is there is no statutory law in our country which enforces us to call police, even in a maternal mortality case. However, since the death is of a young woman who is generally not expected to die in labor, and since we may be seen as an accused of medical negligence because we are the ones who managed her or we are the ones who operated upon her, that's the reason why it is prudent to inform the police so that the police can come and decide whether there is any suspicious surgery that we did. And if required, the police will ask for a medico-legal PM, which means the answer to the second question is the onus of convincing the relatives for PM, that is the medico-legal PM, is upon the police. You don't spare, you don't sweat there and you don't try to convince the relatives that this body PM ke liye leke jana padega. It is for the police to do. And if you are knowing the cause of death, can you give a death certificate even in a maternal mortality case? Again, the answer is no law prevents us from giving a death certificate if we know the cause of death. Again, however, since it is a young patient not expected to die in childbirth, and since you may be seen as an accused of medical negligence, it is prudent to convince the police to ask for a medico-legal PM. Court will accept a cause of death given by the PM surgeon more than that has been given by you, because you are one of the accused doctor, because you are the ones who operated upon her. But we must know our right to give a death certificate even in a maternal mortality case. Now, many a times when it is a maternal mortality, people argue that the appropriate authority, when they do the death review, that is the time they will come and they will tell you कि तुमने postmortem क्यों नहीं किया. So you have to understand that the appropriate authority doing maternal death review has no authority to judge us or to punish us on the issue of medical negligence. They cannot pull us for this fact that we gave death certificate and we did not ask for a postmortem, because it is your right. You were treating the patient. It is your right to give a death certificate if you know the cause of death. Their duty, the duty of the appropriate authority, is to just do a review, suggest healthcare policies, and nothing else. So that is what we have to remember, that it is our right to give a death certificate if we know the cause of death, even in a maternal mortality case. And lastly, I think only three things. One is, at least you must have a 1 crore indemnity, because gone are the days where you can have a 5 lakh or a 10 lakh indemnity and do practice. Now at least 1 crore indemnity, and Foxy has got a wonderful policy. Go there. I have taken a 2 crore indemnity. Some of our Foxy members have also taken 3 crore and 4 crore indemnity because they are practicing in South Bombay. For me, 2 crore indemnity is good enough. For, I think, anybody practicing anywhere in our country, minimum of 1 crore indemnity is required. Second thing that you must have is you must be very good friend of people like Hitesh or Gitendra or Manish and Gupte sir. And if you cannot reach out to them, then I'm always there. My number is 9822038583 and this is my email ID. You can contact me anytime and I'll be there to help you. Thank you very much for a patient listening.
Thank you so much, sir. I think giving us everyday examples and telling us what are the practical points of it makes such a big difference. Yeah. I can see that Kiran Kurtakoti sir has also joined from the Star Endogen conference, I think live from the workshops itself.
Yes. Yeah. Thank you, Dilip, for that lucid talk.
Kiran, what is it that you're wearing on the top? क्या टोपी दिखा तेरा?
I think he's wearing an ECG scrub cap. I think his network's a little bit off. But sir, I think it's a fantastic talk. And sir, thank you for telling all our viewers that you're always there for us for any advice that we need. So thank you for being there for.
And my advice, by the way, is free of charge. I mean, some of the names that I mentioned there, they will charge for you, and I'm there anytime, anywhere.
Thank you, sir. Thank you, sir, for always being there. Rather, I've been working with you for the last 4 or 5 years now, and so it's always a pleasure to hear your talks because they're so lucid and clear, and they give a very crisp message to all our viewers as well. So thank you so much, sir, for such a wonderful talk. So I don't think there are currently any questions, but I think we may get some questions along the way. So in case there are, so we'll pass them on to you as they come, sir. Thank you so much, sir.
Wow.
Thank you, Dr. Dilip Parke, sir. Dr. Kiran Kurtakoti, sir, is back with us. I think he was in a patch where there was poor network. I can see him coming and going. If there are any comments, sir, please feel free to speak. I think he's gone off again. So can I request Dr. Padmaja to introduce the next speaker of the day, Dr. Supriya Jaiswal? Meena, can you please share?
Thank you, Dr. Pratik and Amogs, for including me in your meeting today. And it's my pleasure to introduce another young person, Dr. Supriya Jaiswal, who's the secretary of Patna OB-GYN Society. And she is a communicator center of ISOPAB. She's worked with adolescent committee, and she's an executive member of ISAR and IAG, Bihar and Patna chapter, trained in colposcopy. You can see that she has a lot of awards and certificates. And she's got awards for the best short paper in obstetrics and held multiple positions and was the organizing secretary for a large number of conferences. And her interest being high-risk pregnancy and preventive oncology. And we welcome Supriya for your talk on sustained release progesterones.
Yeah. So good afternoon, everyone. I bring greetings to you from Patna and in capacity of Secretary Patna OBGY Society. Thank you, Dr. Padmaja, for the wonderful introduction you gave. And at the outset, I would really like to thank AMOG's Endocrinology Committee for giving me this opportunity, especially Dr. Pratik Tambe, sir. Sir, it was wonderful to come and be a faculty here. And all the best for your ISAR elections. I've already voted twice. The second time I succeeded because I took precaution, not voting very soon because of the technical glitch. Thank you. All the best. And then I would really thank President AMOGS, Dr. Nandita Parshidkar, ma'am. She's a lovely and sweet lady, very dear to us. Secretary Dr. Arun Nayak, sir, and the whole team. I would a special word for the chairperson, Dr. Kiran Kurtakoti, sir, and then Dr. Padmaja. Dr. Padmaja, ma'am, really very close to you. Many a times we have interacted on the webinars. Dr. Rohan, a very good friend of mine, and Dr. Hafizur Rahman. I had shared with you so many times on the RCOG platform. Then, and really a word for Dr. Dilip Valke, sir. Really, his presentation was awful, wonderful presentation. So, with these words, can I start my screen share, sir?
Yes, ma'am. Please go.
Can you see? Are you able to see my slides?
Yes, ma'am. Please go.
Okay. So my topic is medroxyprogesterone acetate in the management of endometriosis associated pelvic pain. So today we are going to focus on endometriosis more. And because it is, as clinician, we really come to every day, almost in our practice, we really face this problem with the young adolescents and many people. So this is a very commonly seen problem. So a word about endometriosis. It is defined as the presence of normal endometrial mucosa abnormally implanted in locations other than the uterine cavity. So 30 to 40% of women with endometriosis will be subfertile. This is a universal fact because the morbidity is too much with this disease. It is an estrogen dependent disease. Condition is poorly understood actually, very confusing also. Extremely debilitating, benign gynecological condition. And once you see the histopathological picture of the endometriosis, it shows hemosiderin laden macrophages, that is brown colored, you can see on this slide. So it affects usually 6 to 10% of women of reproductive age. About 80% of women with endometriosis present with pelvic pain, and 50% coexist with infertility. These are the main features. So data from Indian study, they say retrospective study conducted in 372 infertile patients, approximately 48% of infertile patients were found to have endometriosis. So you can understand the extent of this disease and most commonly found. Presentation and clinical course, usually you come to see 1/3 of women are asymptomatic. But then 2/3 they face real problem like deep dyspareunia, dysmenorrhea. Dysmenorrhea is a very common feature. Fatigue, weariness, chronic pelvic pain. This is also, they keep on telling that they have deep pelvic pain during the periods. Then cyclical intestinal complaints are there and infertility. So endometriosis is found in 45% to 82% of women with chronic pelvic pain. So usually it presents in a study conducted by Bellis et al. In 2010. Dysmenorrhea was the chief complaint. As I said, it was reported in by 62% of women. Chronic pelvic pain was 57%, dyspareunia was 55%, cyclical intestinal complaints were 48%, and infertility 40%, and incapacitating dysmenorrhea 28%. Infertility along with dysmenorrhea, you came to see 28% in cases. So what are the pathophysiology involved in this endometriosis? As we know, it increases production of estradiol, increases intrinsic aromatase activity, increases production of inflammatory markers that are the real nuisance, the problem makers, then progesterone resistance. How do you diagnose? The definitive diagnosis of endometriosis can only be made by the histopathological pathology showing endometrial glands, that are the markers of that, and stroma with varying degree of inflammation and fibrosis. No serum markers are currently available that can diagnose endometriosis. CA-125 levels can be elevated, however, it has limited clinical utility as the levels can be elevated in other conditions as well. Most of the time we go for CA-125, but then these levels may make you panic and they make you aware of many diseases. Your mind goes in many directions. So you cannot just diagnose endometriosis on basis of CA-125. So imaging studies like ultrasonography, CT, MRI are helpful in cases of ovarian cyst or adnexal masses. Patients with persistent symptoms after empiric treatment should be referred for laparoscopy, the preferred method for diagnosis of endometriosis. So we have got many management options. So we divide them into medical and surgical. So medical, you usually give analgesics, that's NSAIDs, progestrogens, oral contraceptives, androgenic agents, then like danazol, very commonly used, then gonadotrophic releasing hormone analogs, goserelin and leuprolide, antiprogestogens. Then surgical, coming to the surgical part, it is laparoscopic surgery that really gives good result, and endometrial ablation at times. So medical management is offered first. In all cases, we first go for the medical management, reserving surgery for resistant or recurrent endometriosis. Now coming to progestins. Progestins are the mainstay for the treatment of endometriosis. For over 50 years, like long back we used to hear about this, oral progestins have been demonstrated to be effective in the treatment of endometriosis, reported to reduce or eliminate pain symptoms, in approximately 90% of patients, because the pain was the main symptom usually, progestins in resolving endometriosis related pain. This is a table of classification of the exogenous progestogens. Classification is mainly natural and synthetic. So you can see this table. Coming to the summary is 17 alpha hydroxyprogesterone derivatives have substitutions at C17 that slow down the hepatic metabolism, that is MPA, that medroxyprogesterone acetate. 19 testosterone derivatives, this is the norethindrone, and then replacement of the 13 methyl group of norethindrone with a 13 ethyl substituent are more potent progestins and less androgenic. They are norgestrol and nomigestrol. So coming to the mechanism, what do the progestins do? How do they act? They create a low estradiol environment and inhibits the growth of ectopic endometrium. So wherever other places the endometrial tissue, so they are suppressed, the activity is suppressed. So effects on endometrial morphology, local modulation of immune response. So it suppresses the immune response so that due to these TNF alpha inducer, these factors are suppressed, inhibits ovulation and reduces prostaglandin production. So due to this, finally, the ESHRE guidelines and SOGC guidelines, they say that significantly improves pelvic pain, effectively improves dysmenorrhea, deep dyspareunia, and non-menstrual pain. Oral progestins are considered as first-line treatment for the management of endometriosis. So these are the derivatives of progesterone. As we know, less androgenic properties. They also possess moderate to strong progestin action. Most commonly used synthetic progesterone as it is available, structurally most closely related to the progesterone. So here are some of the clinical trials. So phase 3 trial in India, female age patients of age between 18 to 45 years were placed. Patient diagnosed with endometriosis associated with pain based on imaging studies, that is ultrasonography. Patient with endometriosis associated with pain having a score of at least 30 mm on VAS. Treatment duration was 90 days. So 198 women were subjected to this, and out of that 10 patients were not included. 186 randomized patients were there. So here first group were given 93 patients were given medroxyacetone acetate tablets 10 milligram, and here 30 milligram were given to the another 93 patients. Though later on, the primary efficacy endpoint result was mean change in endometriosis associated pain with baseline to end of this study assessed by a visual analog scale. Then reduction in the size of the endometrioma as calculated by USG from baseline to end of the study. Consumption of rescue pain medication from baseline to end of the study was seen. Changes in resistive index and pulsatility index of ovarian blood flow was also seen. You can see these graphs. These they show that mean change in endometriosis associated pain from baseline to end of the study in both the trials. Then there was reduction in the size of endometrioma as calculated by the USG study. Then there were also results showed consumption of rescue pain medication from baseline to end of the study till the last. Changes in resistive index of ovarian blood flow. These are the graphs, comparable charts you can see. Changes in the pulsatility index of ovarian blood flow by giving both the doses. So what are the adverse effects? So no drug is without any side effects. So here the adverse effects were nervous system disorders like headache, dizziness, GI disorders, reproductive system and breast disorders, skin and subcutaneous tissue disorders, general disorders and administration site conditions. So most common side effects were headache, nausea, spotting, breast pain, dizziness, fatigue. Side effects were of mild to moderate in severity on giving these medication. No adverse event led to serious adverse events. So no adverse event was very serious. what the trial shows. Phase 3 trial, again, the results where both the treatment groups showed significant reduction in the size of the endometrioma from baseline to end of the study, day 90. Consumption of rescue medication like these ibuprofen tablets we used to give were reduced from baseline to end of the study, day 90, in both the treatment groups. So medroxyprogesterone acetate SR tablets 30 milligram produce statistically non-inferior efficacy in mean change in endometriosis associated pain from baseline to end of the study, that is day 19, when compared to MPA tablets 10 milligram. So management of endometriosis with oral progesterone acetate, again it was 35 symptomatic women with mild to moderate endometriosis was taken, treatment with MPA 30 milligram for 90 days. The results showed improvement or remission in all the cases. 26 patients were treated for associated infertility. 12 of these became pregnant following treatment, and pregnancy rate in those women whose husbands were fertile was 90%. So it gave a very good result. Post-treatment resumption of ovulation was prompt. So oral MPA is a useful therapeutic agent in the management of minimal to moderate endometriosis, particularly when it is associated with infertility. So evaluation of oral MPA in the treatment of endometriosis. So this is a 21 symptomatic women with mild to moderate endometriosis administered oral daily dose of MPA 50 milligram for 4 months. Here it showed the symptoms were reduced. Lots of improvement were seen with dysmenorrhea, dyspareunia, pelvic pain, dyschezia, dysuria, then pelvic nodularity and pelvic tenderness. So oral daily dose of medroxyprogesterone acetate is effective in symptomatic relief and objective improvement of endometriosis. So these were the recommendations. So progestins and dosage was linensterol for 10 milligram, depot medroxyprogesterone acetate 150 milligram IM every 3 months was also tried. Dynogest, this we had already tried 2 milligram once daily. Then MPA 30 milligram oral daily maximum, it can go to 100 milligrams. So these were the dosages for progestins in use of endometriosis. So these were the advances, these updates were given. Lot of trials need to be done again because it is not very common, but the disease is common, but the trials keep on going. And with this, the result was quite good. Oral MPA 30 milligram per day was a good trial, gave good results. So we clinicians, we have to keep on trying every day, and we only try and survey our patient to see the feedback and come to a conclusion what drugs are the most effective in the commonly found diseases like dysmenorrhea, pelvic pain, deep dyspareunia, endometriosis. Endometriosis really brings great morbidity to the patient. Relief from that really helps your patient brighten up her day and follow her normal routine. So in the summary, endometriosis, we tried to sum up telling you like endometriosis is estimated to affect 10 to 15% of reproductive age people, the women. The most common symptom of endometriosis is pelvic pain. That is really troublesome. It really hampers your day-to-day activities. Progestins are recommended the first line for suspected or confirmed endometriosis. High-dose oral progestogens are effective in reducing endometriosis-associated pelvic pain. MPA 30 milligram bioequivalent to 10 milligram TID medroxyprogesterone acetate, clinically proven effective in improving pelvic pain in endometriosis. So with this, I come to the end of my presentation. Thank you very much for your patient listening. Thank you.
Thank you, Supriya, for the crisp talk. And as you rightly pointed out, not every endometriosis is the same. We are coming to realize like how not every PCOS is the same. There are different phenotypes like that. Even in endometriosis, the biological activity, what is the inflammation? Some of them have severe pain. You don't see such clinical disease. Some of them are very asymptomatic with till stage 4 frozen. So we need to customize our treatment protocols, and not everyone responds to the drugs in the same way. Not everyone perceives the side effects in the same way. So this will be one more molecule in the armamentarium, which we can consider if nothing else is working. But only thing that we want people to realize is this is a disease for life. It will persist till menopause and continue. So we need long-term treatments, and it is not just a course of 3 months or 6 months and end of the story.
Yeah. Thank you very much. Thank you, ma'am. Thank you for your inputs. Thank you, Pratik.
Thank you, Dr. Supriya and Dr. Padmaja, ma'am. I think this is a very initial preliminary study where we had small number of patients. We need to use this molecule more widely. I think it's available widely now all over the country. It's also quite cost effective. The standard drug which we've been using for quite a few years now is Gynogest. This is one more addition to our armamentarium. Maybe some patients we could try this also, and hopefully we will be able to reproduce such good results in large numbers as well. For those of you listening in the audience, this is a very good theme for a scientific paper. If you can recruit say 100 or 150 patients, this would be an excellent publication. You could get published in the Foxy Journal as well, or even in an international journal. We have with us Dr. Hafizur sir, and there are more than 1,000 viewers who are logged in waiting to listen to Dr. Tabassum. If any of you have any questions, please post them in the chat box, because we'll have the Q&A session after Dr. Tabassum has had the talk. Requesting Dr. Hafizur sir to please introduce the next speaker.
Dr. Pratik, there's just one question.
Yes,
because afterwards, I think Supriya also has to leave. Supriya, oral progesterone to be used, first pass can't be prevented, poor bioavailability. You saw the question? Unmute yourself.
Yes.
In the chat box.
Yes, ma'am. So,
oral progesterone, first pass, bioavailability, any comments on that?
Yes, you can use the oral progesterone also.
I think the bioavailability question is with the natural progesterones.
Yes.
Medroxy is always bioavailable orally.
Yeah.
And moreover, it is sustained release, so there are coatings which will ensure that there is good bioavailability, and that will be sustained over a period of at least 12 to 18.
Yeah.
Yes.
Please go ahead.
Good afternoon, everyone. Thank you, Pratik sir, for inviting me, and I am sorry because I have been a little bit disturbed by my net. So we have another important topic is going to come up. So and that is none other than Dr. Tabassum Dalla. We see her, that is she's a specialist in diploma in minimal access surgery and consultant obstetrician and gynecologist and director at Zubaista Hospital at Raipur. She's specially trained in ART techniques and advanced ultrasound, and she's an active member of Foxy as well as Raipur Obs-Gynae Society, and she's the General Secretary of Raipur Obs-Gynae Society. She has presented many papers and won many awards. So this is an important topic because many of the viewers or listeners would like to know that is what are the situations where you can use intrapartum ultrasonography. So without wasting much time, I would like to request Dr. Tabassum Dalla to start his presentation, please.
Thank you, Dr. Hafizur Rahman, sir, for kind introduction. At the outset, I would also like to thank the organizers, especially Dr. Pratik Tambe, sir, for inviting me today for this prestigious webinar happening today, which is hosted by stalwarts like you all. Thank you so much. It's my privilege to be part of this. I would. 1 second. I'm trying to share my screen. Just a second, please. Excuse me.
Yes, ma'am. Take your time. Be comfortable. I think some technical issues, so we'll wait for Madam to be comfortable and to start sharing.
Yeah, there was one more question, Dr. Supriya. We can address that in the meanwhile.
Yes, ma'am, go ahead.
They say dysmenorrhea occurs with progesterone withdrawal that we use medroxyprogesterone. So how can medroxyprogesterone itself be a treatment for dysmenorrhea?
No, sir, in higher doses, actually, maybe once you start with the higher doses, it it controls the dysmenorrhea. So withdrawal, there is a reality that by withdrawal, there might be a little bit of pain, but the recent trials show that higher doses of 30 milligram is helping out in this dysmenorrhea.
And
I think it's important to understand the changes that are induced in the endometriotic deposits by progesterone. It causes desiccation, it causes drying of the lesions, and it ensures that the local production of cytokines, prostaglandins, and inflammatory substances is reduced. The main issue is that the prostaglandins and the cytokines are the ones which cause the pain, which cause dysmenorrhea, which cause cramps.
Cramps, yes.
If you give progesterone in slightly higher doses, then all these are going to get suppressed, if I'm not mistaken. Do correct me if I'm wrong.
And the other thing is, you're not giving it in the luteal phase. You're not letting an estrogen grow and then give progesterone. You're giving progesterone continuously, which is also suppressing the hypothalamo-pituitary axis. There is a little amount of hypoestrogenism, and estrogen is the one that is causing the expression of all the prostaglandins, aromatases, and all that.
Yeah.
So inhibiting it at that level.
Yes, ma'am.
Since Dr. Afizur sir is here, I have heard that in Northeast, the incidence of endometriosis is quite common. Is that your experience in clinical practice as well?
That's true, sir, because in Sikkim, we also see there is a quite prevalence of endometriosis, because many of the girls or these young ladies, whenever came to us, and many of them are actually quite reasonably, we are in a clinical syndrome and examination, we are able to find out that endometriosis is quite prevalent actually. Now maybe it is required why this geographical distribution might like Sikkim in high altitude, everything is there. So that may be able to address in future actually. But yes,
maybe it's something to do with being rice eaters also. That's also one thing.
Yeah.
Coastal areas, rice eaters.
Yes, sir. Yeah. So that right connection, or maybe many of the places are actually like high altitude or hilly, like in Sikkim. Now we see quite a few like that. So those may be, if there is anything, is just.
Do you have any experience with using medical management as opposed to surgical management?
Yes, sir, we do use that, because as Dr. Supriya was taken up, many times we use actually the medroxyprogesterone, and I would like to also say that drugs works wonder for many women actually, and just relieve quite pain, and patients remain symptoms free. And sometimes we prescribe, and next time we see the patient, we feel the smile, see the smile in their faces actually.
Dr. Padmaja, what is your experience with endometriosis?
Is
it quite common where you practice in Vijayawada?
Overall, I feel it is increasing, because the age of marriage is increasing. People are BMIs are high, they're obese, they are anovulatory, they're hyperestrogenic. So whatever that reflux tissue of endometrium is there, the endometrium is shed not because it's a non-viable tissue. It is shed because it's grown too much and there is no baby. So that viable tissue being shed into the peritoneal cavity overall is increasing. And I feel the plastics and the chemicals in our food have increased, and all these endocrine altering substances are causing neoangiogenesis and survival capacity of the endometrium. So, and the number of children also have decreased. Many people have only a single child now. So with all these being increased, because even till 15 to 20 years ago, the average marriage age in Andhra Pradesh was around 18 to 20 years. So they would have their first child by the time they're 22. So they're not exposed to so many menstrual cycles. Now the age of menarche is 10 and the age of marriage is 26, 27. So I feel that also is hampering and contributing. And we are having also male factor contributing to infertility. So everything makes them have less number of children, more menstrual cycles, and all this is also adding up. Previously, it never used to be. When I started practice, I used to see maybe 1 or 2 endometriosis cases a year. Now I see weekly 2. So you can see the incidence.
Incidence is definitely shooting up, and many of these women, maybe after 5-10 years down the line, are going to be good candidates. They are going to present with chronic pelvic pain, recurrent endometriosis, stage 3, stage 4 disease, previously operated on, who you don't want to touch again because you don't know, they might have bowel rectum adhesions, and these are very difficult patients to tackle, even surgically. So I think these are very good candidates, especially if you're thinking of medical management, long-term therapy, prevention of recurrence, offering them an alternative which will restore their quality of life. Try and give them something which will tide over so that at least their daily life is not impacted. So many of our patients who have stage 3, stage 4 are just bedridden and they can't do anything else. They can't contribute to society, to their family, and they are looked upon like a burden.
Yeah.
Very sad state of affairs.
And that is one of the reasons I think the intrauterine progesterone devices for especially people with heavy menstrual bleeding, have finished their family, using this as a long-acting reversible contraception is a good option. It will treat their menorrhagia. We don't need to do a surgical procedure. We don't, and it will prevent these endometrial hyperplasias. So I believe we should be adapting that more.
Excellent. Good point. Dr. Supriya ma'am, you work in a government setup. What is your experience? Do you find that sometimes the diagnosis is quite delayed because we tend to just dismiss patients who have dysmenorrhea, normal hai kuch nahi, Meftal spas le lo, theek ho jayega?
Yes, sir. Sir, I've been working in government setup since 10 years and my own setup also. So more of my private patients, I feel they are having this, and we diagnose early, but in the government setup, they just, yes, as you rightly said, they come take some painkiller, and before consulting us also, they search the Google, take the painkillers and come to us. So delayed diagnosis is very common, sir.
And that is where the entire problem lies, because if you don't diagnose it in time, it's a progressive disorder and it's going to destroy whatever little chance she has at fertility. As
Yes.
Dr. Padmaja ma'am rightly pointed out, the delay in diagnosis, delay in marriage, delay in having the first child, all of these contributory factors are leading to an explosive increase in the cases that we are seeing. Is Dr. Tabassum there? Has she come back? Meenal, do we have her with us?
Yes, sir. There's some problem with the screen share, so I've mailed my presentation to her, Meenal.
All right, great. No worries. Let us know when you're ready to start. We're just chatting here because we've got 5 minutes extra to talk to each other.
So she has joined with some other device, I believe.
Yeah, I think she's just getting the issues.
And comparatively, I feel if we look close enough, in almost half the endometriosis, we will have an element of adenomyosis.
Yes.
That is becoming more frequent, especially in patients who put off childbearing for a very long time.
Yeah. And that is a double whammy, because not only are they having the pelvic pain, that whenever they have this intense, they will typically tell, I can feel a flooding episode.
Yes.
So that in adenomyosis, because of that blood vessels also being open up, fibrotic tissue being there. So it is like once the surface epithelium is gone, it just gushes out because the natural living ligature mechanism is also not there.
That is impaired, yes. Very good. Tabassum ma'am, comfortable? Can we go ahead?
So I think
sir, Meenal need to share the screen, whether it's there or not there, because she has made it.
Just give them a minute to solve it.
One of the warning signs for adenomyosis is if you are, whenever you do a scan, you start looking at the uterine volume. So usually in nulliparous, the uterine volumes are around 30-40 centimeter cube. A multipare is around 60 to 80. The moment it goes beyond that, even if you don't have those typical features of adenomyosis, start being alert, so that it's always the same. No, the mind can see, realize what the eyes, what they're first seeing. The mind should know to interpret them. So unless we are that super alert, we will not pick up. You will think it's just a myohyperplasia, because now with obesity, and I feel my clinical skills are so bad that I could not really say it's a 6 weeks uterus, it's an 8 weeks uterus, it's a 10 weeks uterus on a PV examination. I rely on my uterine volume measurements. So that will also warn us.
Madam, it's true that by manual examination or per vaginal examination is difficult to assess, because some people are very obese, the ladies, and it's difficult to assess both ways. So we should depend on these ultrasonography, especially TVS, I think.
Any experience with using color Doppler or 3D ultrasound in your clinical practice? Not specifically just for endometriosis or adenomyosis, but do you think it's relevant? And we have started using this more and more in our clinic.
High-end 2D ultrasound as a screening test is very good. Color Doppler adds to it, because when you have local adenomyoma, fibroid, adenomyosis, that sort of thing, I don't use the 3D on a routine basis, because I find it consumes a lot of time, because once you get into that, you would like to take more planes, you would like to do this thing, your OP is waiting, and you get into, you want that vascularity, you want to see the endometrial VOI, vocal, and things like that, you get lost in it. So for a practicing gynecologist, doing your own scans, finish your pervaginal examination, you will see the tenderness. And one more thing is, do it during the day 2 of your periods, because the disease has come out well. Thank you.
I think Dr. Tabassum is back with us, and she's managed to share her screen. So the stage is all yours, ma'am. Please go.
The screen share.
Can you see my screen?
Yeah, we can see it. If you can make it full screen, try and do that.
Good.
Perfect.
Yeah. Can you see the screen now?
Yes. Go ahead, please.
Okay. So thank you, Pratik sir, and thanks everyone for and sorry for giving me time. I'm so sorry for the delay. So this is something very different from what we normally studied. Normally we were studying digital examination, and we were seeing dilatation and the progress and everything. And junior doctor was, resident was doing some PV examination and informing to the consultant, and the consultant was like, no, this was 3 centimeters. And then consultant is saying, no, this 4 centimeters, 5 centimeters. How do you know it? So digitalization has made things different, and I think let's see if digitalization is going to come to obstetrics as well, and change the scenario how we treat our patients. So what is the basic setup of ultrasound? What do we need? We need a simple 2D machine. Then what probes do we need? We would need one abdominal probe, a 3.5 to 5 hertz, normally what we use during our ultrasound. And the route of examination would be abdominal or transperineal. So most of us have this setup, and I think most of us can start doing the basic ultrasound in labor. So coming to the transabdominal. What is the technique for transabdominal? You have to see when the patient is lying supine, you have to make her lie supine. What would be the transducer position? It would be a transverse on suprapubic region on maternal abdomen. What are the landmarks we are going to see? The first thing we are going to see is the orbits. Can you see the orbits? How do we see in ultrasound? It would be 2 black holes. So always remember 2 black holes. Then midline cerebral echoes midline cerebral echo, and then we would see the cerebellum. So what are we going to detect by this? We are going to detect the engagement and the position. So this is how we are going to keep the probe on the abdomen transversely, and this is how we are going to see. If we are going to see two orbits facing towards the probe, that means it is occipito-posterior, yes. And this is how the ultrasound picture looks, which is black hole. So remember the black hole. Now coming to transperineal ultrasound. It is also called as translabial ultrasound. Position, yes, the supine position. Transducer, it has to be kept in mid-sagittal between the labia below symphysis pubis. What landmarks we are going to see through transperineal? We are going to see fetal orbits again. We are going to see midline cerebral echoes again. We are going to see the cerebellum again. So what all we are going to diagnose by this? The position, fetal head position, the progress of labor, and also the prediction of labor. Okay, so I think we are going to forget Bishop's score after this. So this is how it is kept. Can you appreciate it? Transverse, it has to be kept longitudinally, translabially. Transperineal ultrasound is used for detection of number 1, position, number 2, progress, and number 3, prediction. Prediction of success of labor. So how are we going to predict the success of labor? Success of induction of labor. If by transperineal or transabdominal sonography, if your cervical length is less than 20 millimeter, if posterior cervical angle is more than 99.5 degrees, the position of fetal occiput, if it is occipito anterior, and if the head and the perineal distance is less than 40 mm. One by one, we are going to see each one of this. Cervical length, I will not going to say because everybody knows how to measure the cervical length. The second was posterior cervical angle, and this is very important. When we are measuring the cervical length, we have to draw a line and then transversely go to the transverse line of the cervix, and the angle which is formed in between these two lines is the posterior cervical angle. And this posterior cervical angle, if it is more, then the cervical length is shorter. If it is less, then cervical length is longer. So what was our prediction point of posterior cervical angle? It was more than 99.5. If it was more than 99.5 angle, bigger angle, then we have a good chance of normal vaginal delivery. Coming to the head perineal distance. So we have to see how away the head is from the perineum. Okay. So we have to keep the transducer like this, transversely, and then see the head perineal distance. So this is the skin and the perineum and the head. So the shortest distance between the leading part of fetal skull to the perineum is called as head perineal distance, and this is how it can be measured. Shorter the distance, good chance of normal delivery. Now coming to the skull contour. This is the way we are going to do it. This is our own picture. So this is the fetal head, the leading part of the fetal head there. We have to draw a perpendicular line from the skin, and that's how we measure it. So now why ultrasound in labor? Why are we doing ultrasound? Why don't, it was like a long done Bishop score. Why are we leaving it and coming to this? But what I would say is we are not leaving it. This is one extra added advantage for us by including ultrasound in our practice with digital examination. Why? Because several studies are saying it. Several studies have shown that ultrasound examination has got better correlation with gold standard MRI than digital examination. You can see the vaginal examination was correct in 71.6% of times. Ultrasound was correct in 92% of times. So you can see the difference. And so many studies are proved when they were comparing with the MRI, standard digital examination versus ultrasound examination, and they found the correct they found that ultrasound examination was better correlating with MRI studies. So determining the position by ultrasound. So how are we going to determine the position by ultrasound? Same, keeping the transducer straight on the abdomen, transversely. And if this is the fetal head and this is the ultrasound transducer, what we are going to see is, if we are going to see the black holes, the orbits, then it is occipito-posterior. Midline cerebral echoes means it is direct occipito-posterior. If it is towards the maternal right, then it is left occipito-posterior. If it is towards the maternal right, it is left occipito-posterior, right occipito-posterior. And if it is transverse, then it is occipito-transverse. Yes. So these two black holes, can you see, appreciate the black holes here, both the orbits. So now we know that it is occipito-posterior position, right? So these are various diagrams to show how it looks. And it's very easy to, you trust me, it's very easy to do it. Next time when you go, when you are seeing a labor patient, take her to your OPD first and put a probe, and you will be able to appreciate. Now, how do we know the transport occipito positions? Yes, definitely the occipito-transverse position. First, look for the orbits. Second, look for the sagittal echoes, mid-cerebral echoes, and the cerebellum. And that's how we would be able to see different positions of fetal head. So this is how we can see the left anterior occipital position. Here, the right anterior occipital position. But we should ideally be seeing both orbits together. Right transverse occipital position, left transverse occipital position, right occipito-posterior position, okay, left occipito-posterior position. And if we are not seeing both orbits and we are able to see only one orbit like a circle there, then it is asynclitism. So we can also diagnose asynclitism by ultrasound. So this is how it goes. Right anterior occipital position with posterior right asynclitism. If you go like this, right posterior occipital position with posterior asynclitism. And this is a direct occipito-posterior position. Ultrasound to determine the station. So how are we going to determine the station? So head to sacral tip, the distance from the fetal head to the sacral tip was less than or equal to 4 millimeter. Then the head was always engaged. So if we are confused sometimes that head is engaged or not, do an ultrasound, see if it is less than 4 centimeters, then the head is always engaged. So we are confirmed with this. We need not wait for, get confused with the caput and the molding and everything. BPD, below pubic inlet. Okay, the fetal head was considered engaged when on transvaginal digital examination, the leading part of the fetal head was positioned at least at the maternal ischial spine, that is 0 station. That is how we have been taught. And when on trans suprapubic ultrasound, the fetal biparietal diameter was below the maternal pelvic inlet. So this is how we are going to see it by ultrasound.
Dr. Tabassum, we are not able to see your screen. Is there a disconnect?
Subbu, good afternoon. Dr. Tabassum's laptop is running out of battery. She's just going to fetch the charger. Please bear with her.
Sure.
Dr. Prateek, so every time we do an ultrasound, we still have to fill up the PCP and DTA form? Because every
In
time.
an ideal world, yes, we are
Because,
supposed to.
because now when if you're going to do so many times.
Yes, and the more important issue is whether we are moving the ultrasound machine from its designated position to the labor room, or it's the patient that is going there. Because ideally, we are not supposed to move the machine.
Oh, I'm sorry about that again.
No
Something
worries,
happened
ma'am.
with the network,
Yeah,
I think.
your battery was low. Go ahead.
Yeah. So what I was talking about was the ultrasound to determine the station.
You had reached the posterior asyncretism.
Station, sacral
Station.
Ma'am, do you want me to share the screen?
Just 1 second. Yeah, please share then.
Please let me know which slide.
You'll have to go ahead, Meena.
Ahead.
Ahead. Slide number 30.
No, before this. 2 slides before this. Yes. Next, just the next slide. Yes. So the shortest distance from the outer bony limit of the fetal skull to the skin surface of the perineum was measured in a transverse view, as we saw later. A cutoff level of 45 millimeter was used to define head engagement. This corresponds to a fetal head position beneath the ischial spine. Next slide, please. So what is the angle of progression, which is very important? The angle of progression is measured as the angle between a line through the pubic symphysis and the line tangentially to the fetal head. A cutoff angle of progression is 120 degrees. There would be at least 90% of chance of safely delivering the baby, either by vacuum extraction or by spontaneous vaginal delivery. Next. So this is how we are going to measure the angle of progression. A line tangentially drawn at the inferior border of pubic symphysis and taking an angle towards the fetal head, the outer border of the fetal head. And that's how we can diagnose the angle of progression. See, the first way up there is a 92-degree slide, and the second one is 135 degrees. So 135 degrees angle is progressing. You can also see caput there. So we are going to avoid that caput here. So it would be more accurate than digital examination. Next slide. Yes, this is how it is done. Next slide. This is also same thing. Next slide, please. Yes. So this is a very important slide where we would know the important points where we are going to find diagnose things. When the fetal head was directed downwards, we have to see the direction of fetal head. So if the fetal head was directed downwards, the station most frequently assessed clinically was less than or equal to +1 centimeters from the ischial spine. So direction of the fetal head is also important. If it is directed downwards, then when the fetal head is directed horizontally, the station was most frequently less than or equal to +2 centimeters. When the direction was upwards, the station was usually more than or equal to +3 centimeters. So that is how we can find out how we are progressing. Failure to visualize a cerebral midline or a rotation more than or equal to 45 degrees was associated with a station less than or equal to +2 centimeters. A rotation of less than 45 degrees was associated with a station more than or equal to +3 centimeters. The probability of a station more than or equal to +3 centimeters were particularly high when an upward direction of the head was combined with a rotation of less than 45 degrees. Next slide, please. So this is how we are going to assess the head rotation. Next slide. Yes. So this is how we see the angle of progression. Line join the progression distance, inferior pubic line, and then a straight line joining the last point of the fetal head perpendicularly to the last point of the fetal head. So this would be the angle of progression. Next slide, please. Direction of the fetal head to assess the station. Next slide. So this is how we are going to see this. Distance from the lowest part of the fetal skull related to the perpendicular to inferior border of pubic symphysis. So a line joining the inferior border of pubic symphysis, a straight line, and then you come perpendicular to it, and then see this angle. Can you appreciate the angle? The angle of the fetal skull, midline sagittal angle of the fetal skull. And this angle would tell us if the fetal head is going upwards, it's going transversely, or it is moving downwards. Next slide. So this is the red one there is the angle. And if the angle is more obtuse, that means the head is going upwards. If it is perpendicular, that means head is going horizontally. And if the angle is acute, then it is going downwards. Next slide. So this is the upward direction. Next. Yes. Next slide. Yes. So upward direction and lower direction pictures you have already seen. So what is the clinical significance of these parameters? Head station 3 plus 1.5 centimeters is 92%. There is a probability of vaginal delivery. If head direction is more than 20 degrees, you have 92% probability of vaginal delivery again. And angle of descent, if it is more than 120 degree, there is 93% probability that that patient will deliver vaginally. Next slide. Prediction of success of vacuum delivery. So if it is a head up sign, then yes, vacuum will successfully deliver the baby. Objective descent of fetal head below the infrapubic line, both noted at the height of pushing. You have to see that at the height of pushing. Then yes, vacuum delivery would be successful. And the head direction, as I said, that the head direction is downwards, then good chance of a vaginal successful vacuum delivery. Next. The future of labor room and hopefully for the obstetrician. Next. The TRIAC system. Next. So what is this? TRIAC Medical Labor Pro System provides professionals with accurate, non-invasive image and ruler-like measurements, increasing the data available to make better labor management decisions and lower the risks. The Labor Pro system consists of position sensors, ultrasound imaging, a user-friendly software program, and disposable items. The system can use external ultrasound input or be configured with an integrated ultrasound unit. This system is also equipped with a 3D graphical display to enable mothers, nurse, midwives, and physicians to visualize the labor progress and labor process, and a built-in data activating and data management program to enhance the hospital's obstetric risk management system. So I think medical legally also will be better after we have this. Next. So let's keep advancing with the advancing times, and soon we will realize that things are becoming simpler and life easier. Next. And the obstetrician of the future would be the obstetrician, the man with the machine, collaborated together. Next slide. So even obstetrician needs to relax. It's a healthy choice. Finally, the take-home message would be intrapartum sonography adds significantly to conduct of delivery, both normal and instrumental. It can't replace the clinical skills, but can definitely change the way we predict and assess the progress of labor. Best predictor for induction of labor success in cervical is cervical length, but transperineal ultrasound. Progress of labor is best assessed by angle of progression. Thank you very much. And sorry for all the glitches there.
Yeah, thank you, Dr. Tabassum. I think it was a very nice presentation, even with your demonstration with the skull also. That's really good.
Thank
and
you.
I'm sure this will help our many of the viewers to have use ultrasound wherever it's available, especially in labor room, suppose we are just like we have got an ultrasound room in labor room. So that can be used as a supplement whenever feel if there is something in doubt, and that may be really helpful. And I'm sure it may be helpful from your demonstration as well as your the very nice description.
Thank you very much.
Thank you so much. Yeah, Pratik sir.
Thank you very much, Dr. Tabassum. You soldiered on through all the difficulties. Dr. Padmaja just put a question while you were away from the desk, and that's the issue of the PCPNDT Act and the F form. So how many F forms do you fill up daily because you're doing intrapartum ultrasound?
That's true. I have not thought about it till now, but yeah, that we have to go on filling maybe. I think that one F form will last for 24 hours. So we will not allow the patient to go beyond 24 hours. So one F form would be enough for one patient.
I know, but it needs to be done. That documentation has to be there. And
yes.
Of course, our staff also have to be trained that this needs to be filled in and this needs to be dispatched as per the regular F forms which we fill in for antenatal obstetric ultrasounds on OPD basis as well. That is the one addition that maybe you could make beyond that. We've had 3 excellent talks, and I would invite the chairpersons for any closing remarks. I don't see any fresh questions from the audience. We have 1,151 viewers today, which is really fantastic. And it's amazing, despite it being a weekday afternoon, that we have such a large audience. Thank you very much to the Science Integra team for working hard in the background to bring such a lovely audience. Also to our academic partners, Torrent. We'll have some closing remarks from our chairpersons before I present the formal vote of thanks. Dr. Padmaja, ma'am.
I really enjoyed all the 3 talks. I was hoping to pop in and pop out, and I stayed on, and that is the greatness of all the 3 talks. And thank you, Dr. Pratik, for including me. And Tabassum, I think we really have to work on this and keep awake. I mean, it makes us start thinking about how well we can use whatever technology we have. Thank you for that.
Thank you, ma'am, for the encouragement. And I hope this is taken far and wide.
Yeah.
I think, sir. Yes, sir. I think all the talks are really excellent. As you have told, so many viewers have logged in. And I'm really hopeful that this will be useful for all the viewers. And at the last, I'd like to say that is Pratik sir, I wish you all the best. I have done my part for USR elections. And I'm sure that is now you are such a nice and humble, and everyone, whoever is now in support of you. Thanks. Thank you so much.
Thank you, sir.
Thank you, sir.
Dr. Supriya has joined back. Dr. Supriya, ma'am.
Yes. No, I was logged in, sir, but then a little bit of work. The anesthetist usually comes late, no? So I've got a time. So may I put my word, sir?
Of course, sir, please go ahead.
I'm also contesting for chairperson Adolescent Health Committee of FOXI. Dr. Hafizur, I have already put my request to you, across to you.
Yeah.
So
I know, madam.
Just need all of your blessings, sirs, Dr. Padmaja and everyone, Dr. Dala.
All the best.
Course, all
the best, ma'am, and all the best, Pratik sir, too.
Thank you. Tabassum, you were saying something before I interrupted you. Please go ahead.
Raipur Obstetrics and Gynec Society and myself, all of us are with Dr. Pratik Tambe.
Thank you so much.
All the best.
So kind of you.
Even we.
So I'll just,
we all.
Thank you.
Yes.
I'll just present the formal vote of thanks at the end of today's wonderful academic session. Gratitude to our beloved President, Dr. Nandita Palchetkar. Madam is the President of AMOGS, as I said, and she is also contesting for the post of FOXI representative to FIGO. That election will take place shortly, so requesting the viewers to please vote for her in large numbers. Thank you also Dr. Arun Nayak, sir, our Secretary. The ICOG Chairperson, Dr. Uday Thanawala, Secretary of ICOG, Dr. Ashok Kumar. Thank you for your blessings and for the ICOG credit points. 4 lovely chairpersons, Dr. Kiran Kottakuti, sir, Vice President AMOGS, live from the OT today with a special ECG cap for those of us who managed to see it. Dr. Padmaja was here right since before even I logged in, and she's here right to the end of the program. Thank you for being so kind and gracious to be with us today. Dr. Rohan Palchetkar, our Joint Secretary of AMOGS, Thank you for joining us for a short time. Again, Dr. Hafizur was here right from the very beginning of the program till the end. Thank you, sir, for contributing and for your lovely inputs. We had three lovely speakers. Dr. Dilip Bharti speaking very practically on medical legal issues with several cases which he illustrated. I think we need to have sir back maybe after a couple of months, that we keep refreshing and we have these unique viewpoints from an excellent academician like him. Dr. Supriya Jaiswal, Secretary of Patna Society, for a lovely talk on sustained release progesterone and how it can be the next big thing. As I said, for those of you in the audience, if you want to publish, this is a very good concept or theme that you can take up, because there aren't all that many studies on this particular molecule coming, especially from India. And last but not least, Dr. Tabassumi reminded me of my undergraduate and postgraduate days when my teacher, Dr. Ajay Mehta, used to do ultrasound, obstetric ultrasound with a portable machine in the Wadia labor room in those days in 1995. So thank you so much for reminding me of those beautiful days. I should also thank the Science Integra team, Subbu, Session, Meenal, who is here today, for providing the academic backbone and for being our support throughout this past 2 years. And last but not least, Torrent, who are the academic partners for today because of Devery and Shellcal XT. Thank you for being with us and for partnering with us for this series. We hope to see all of you in the audience soon in the next event. Until then, goodbye, God bless, and bye.
Thank you, sir.
Thank you.
Thank you. You can take us off air.
Bye. Bye, sir.